Hello, I'd like to welcome everyone to the 6th International Conference on Reproductive Health, Embryology, and Fertility. This is a recording done late August of 2021. I was pleased to be invited to be the keynote speaker to this event. I think because so many exciting things are going on for reproductive health and fertility, around some of the work that we've been developing and studies we've published that wanted to sort of advise everyone about those. We'll be looking at a manual physiotherapy, that is a hands-on therapy that is been shown to increase fertility rates both naturally and via IVF. And we'll get a good look at all of those and the studies to date that have been published. There's my name, Larry Wurn. I am the research chair at Clear Passage Physical Therapy, where we developed so much of this work. You know, reproductive endocrinologists are generally, what a brilliant profession. I mean, these are miracle workers. The fact that they can take a single sperm, inject it into an egg outside of a person, outside of a woman, and then reinsert it within her body, either in the fallopian tube generally or in the uterus, and have life be born is just, you just can't say enough about that. It's remarkable. Reproductive endocrinologists are specialists in the endocrine system and hormones. They so often work on a micro level. This is rendering of pulling single eggs out of an ovary. Here is in perhaps even more remarkable photograph of injecting a single sperm into an egg. Just really remarkable. And as I said, on such a micro level. Manual physical therapy, on the other hand, works on much more of a macro level. It is a level that has scarcely been considered or used in reproductive medicine ever. We're going to look at that. The aim of this physiotherapy is to decrease adhesions and microadhesions. These are the strands that rush in, the inner scars that occur whenever tissue becomes inflamed or damaged. They lay down as the first step in healing. Once the body has healed, those adhesions remain in the body and sometimes decrease function, including fertility, or can cause pain. The aim is to decrease adhesions and prepare the uterus for implantation. We'll look at that. And we wonder if we are possibly improving hormone levels and the pituitary hypothalamus ovarian communication loop. I will leave it up to you after this presentation to help make that determination for yourself. Where we started. We started when my dear wife, summa cum laude physical therapist of 45 years now, she developed cervical cancer. As part of the treatment, they put her in a lead-lined room. They said, we are going to surgically implant radioactive material that are in the stainless steel tubes and balls inside of you to the full depth of your uterus. It's really dangerous for us as nurses to be in the room for more than 5 minutes at a time, but we're going to keep you here with these inserted inside your body for 72 hours. And they did that to her twice. It's an early cancer treatment. It was quite a bit of radiation, as you can imagine. She also received external radiation and surgery. A year later, they had certainly cured her cancer, but she developed debilitating pelvic adhesions. She had what is called a frozen pelvis, where all of her pelvic organs were attached together, glommed together in these straitjackets. Here we can see adhesions which can form either as sheets or as ropes or as balls, like you'd see a group of rubber bands on someone's desk. They just attach to each other. Once they've formed, the body does not have a way to naturally rid itself of adhesions. We have used physical therapy and physiotherapy to treat adhesions for various ailments and debilitating conditions in the body. We just never thought of it before for infertility. But here, my dear wife was in such severe pain, and the doctors refused to do any more surgery. They said they're just going to cause more pain and more adhesions. Learn to live with the pain. We were not willing to do that. So together, she and I took as many physical therapy courses as we thought we could take. We do lasers, microcurrent, different electronic courses, manual therapy courses. Some of the manual therapy courses started to help. We took them in America, went to medical school in Europe for a while to take some courses, and learned a lot about adhesions. We needed to be able to get rid of her adhesions so we could get her life back. We learned that adhesions can form anywhere in the body. They form whenever and wherever the body heals. This is especially true in female reproductive organs. In the vagina, you have things entering from the outside world, going into a warm, moist, dark environment, a perfect place for life to be born. If the things entering there are not perfectly clean, have bacteria there, bacterial infections can occur in the vagina, in the bladder nearby. When adhesions form there as a first response to those infections, and whether the infections are diagnosed or subclinical, the adhesions remain in the body, and it's a perfect place for adhesions to form, really. Well, with my dear wife, she did very well after therapy. 2 years after pulling out the best that we could from these courses and amending and revising those techniques, she had actually no further pain while moving, walking, breathing. She was back at work 40, 50, 60 hours a week and said, Larry, I don't want to treat tennis elbows and post-knee surgeries anymore. There are a lot of people out there with adhesions. I want to treat patients that have adhesions. There's nothing else out there that is helping them. So I assisted her, got a license to treat, and we started treating patients with adhesion pain. Then something unusual happened. We found we were opening totally blocked fallopian tubes. We did not intend to. It just started happening. The first woman that came to us had been infertile with totally blocked fallopian tubes for 7 years. Same boyfriend that whole time. We treated her and she became pregnant. She was shocked. And one of the physicians, a physician friend of ours, asked if we had anything to do with it. We said, well, it's hard to tell. He sent his wife in. He said, you know, my wife, she only has one fallopian tube. It's been blocked for 11 years. The other one had been removed. She's 41 years old now. Do you think you can help her, even if you can help decrease her pain? She had a thick infertility, thick file from multiple endometriosis surgeries. We treated her. She comes in one day. She says, I don't know whether to hug you or hit you. I'm going to be 42 and I'm pregnant. So we started looking at this and documenting what we were doing. We realized that here we see an HSG dye test, hysterosalpingogram, where the straw coming in just beside that upside down R is bringing a radio-opaque dye in and filling the uterus. That's the larger white structure on the left side in the before picture. So you're seeing actually an x-ray of the inside of the uterus, and it fills up until those little horns. That's where the fallopian tubes start, but it does not go any further than that before therapy. After therapy, we have what is called free spillage. That dye is going all the way through the tubes and spilling out into the pelvic cavity. This woman can now become pregnant. Her tubes have been wide open. The more we looked at these images, the more we realized, well, wait a minute, look at this uterus. The uterus in the before picture looks like it's being constricted by a straitjacket. It's whether that's spasm or whether that's adhesions, which is what we suspect looking at her history and knowing about her blocked tubes as well. As we treated that, look at the uterus in the after picture, freed of those adhesions. It's able to move and function. It is much more the anatomy that she probably had when she was 11 or 12 years old. If you're a reproductive endocrinologist, into which uterus would you prefer to place your embryo? Along and along, we had some unusual cases. This is very early on. We were treating hydrosalpinx. We didn't know any better. Hydrosalpinx is when a tube is generally blocked at the end and swollen. Usually there's an infectious process going on. It's kind of like if you hit your knee and it swells up. The same thing happens with the fallopian tube. The woman comes to us and she only had one fallopian tube. It looked about like this. It had a huge hydrosalpinx. She was told, you'll never become pregnant. That tube will never be normal. You would just have to remove that and go directly to IVF. We didn't know any better. We treated her. Here's the result. She had the child on the left just had her 17th birthday a few days ago, and born naturally, conceived naturally, and several months after her birth, the woman became pregnant again and had twins again, also naturally. Well, about this time we were starting to get kind of excited. So we wrote to the gynecologist in town and we said we're helping decrease intercourse pain and pelvic pain, and we're also opening blocked fallopian tubes. The chief of staff of the hospital called me in and he said, Mr. Wurn, I've been a gynecologist surgeon for 35 years. I perform surgery twice a week. I do research as well. What in the world is this about opening blocked fallopian tubes manually? And I handed him a half a dozen charts. He looks at one, he looks at another. By the time he gets to the third or fourth chart, he turns to me and he says, Mr. Wurn, you're doing things with your hands I don't think I could do surgically. And I'm an excellent surgeon. And I said, is that okay? Yes, he says, that's actually fascinating. Are you doing any research? No, I'm not. He said, Mr. Wurn, this is potentially huge benefit to women and to physicians. We need to do some research. Let's do that. So we decided to move on and do some clinical research. We first presented to the American Society for Reproductive Medicine. We were having success in several different areas, in pain, endometriosis. Here's one on hydrosalpinx that was a poster presentation. We had also another poster and an oral presentation there, abstracts published in Fertility and Sterility. That was in 2006. By 2008, we had published our first PubMed searchable study available at NIH. Only 28 patients, but a pretty good size for a pilot study for blocked fallopian tubes. The biostatistician, who is head of biostatistics at the University of Florida, published in Lancet, JAMA, and a little over 100 publications, said that's plenty to get a statistical result, and we had a 61% success rate in 2008 out of those 28 patients. Move forward 7 years, by this time we had 235 new patients, no cherry picking, every single one we could contact that had blocked fallopian tubes when they came, that responded to our surveys and to our queries, we counted. We also had a 61% success rate opening totally blocked fallopian tubes. We had hired by this time a PhD with a postdoc in histology and disease modeling. She works in that very small area where reproductive endocrinologists work, at least at that level, because we wanted to know what in the world we were doing that was helping these women. She said, well, let me just go ahead and look back at all of your data. And she did a 10-year retrospective study on our work and did not just limit it to blocked fallopian tubes, she looked at endometriosis, polycystic ovarian syndrome, even elevated follicle-stimulating hormones, as well as therapy performed before in vitro fertilization. And I believe the reproductive physicians will be fascinated with the results on that one. In clearing blocked fallopian tubes, she found that we were able to open tubes in virtually 69% of women who had had no prior tubal surgery. If they had had surgery on their tubes, the success rate was about half of that. When you think of doing surgery to an organ that is designed to carry single cells, a single-celled egg and a tiny single-celled sperm through that organ to meet, and you cut on that organ, it's the adhesions that form, no matter how wonderful, compassionate, and skilled the surgeon, they cannot prevent adhesions from forming in that tube. So we suspect that's why there was about half that success rate for those patients. 61% overall again. Pregnancy rates were right around 57%, 81 pregnant out of 143 women. 80 of those became pregnant naturally, 1 by IVF. The head researcher looked up pregnancy comparisons with allopathic, conventional standard of care and found studies which you can find at our website in this study, or just search PubMed at NIH, the National Library of Medicine, comparing the therapy to surgical techniques, and you see the numbers there. Along during this time, we were noticing a significant decrease in endometriosis pain. Women would come to us and say, I've been on the floor 2 days a month up until I came to see you. Since you've treated me, my period came. I didn't even know it was coming this time. That's really totally unusual and remarkable for me. What is going on? And of course, we've still hired this PhD to figure out what in the world is going on and why are we helping. Our suspicion was that we are detaching the collagen crosslinks. When endometriosis forms, or any tissue damage forms, these tiny strands, like the strands of a nylon rope, come rushing in and start laying down upon each other in a random pattern, creating an internal scar, and that's what we call an adhesion. Those little strands shown in white here, they're very strong, 2,000 pounds a square inch is the estimate, which is 140 kilos per square centimeter. So we have to suspect that we are not breaking those strands, but where each strand attaches to the next, and then the underlying surface, there is a molecular chemical bond. We suspect that when we're treating, we are somehow dissolving or detaching that chemical bond, and in doing so, it's like pulling out that adhesion, like pulling out the run in a sweater in very slow motion. We believe what happened with these endometriosis patients is we detached the bonds at one end or the other, so the endo remained there, the collagen fibers still remained there, but there's collagen already covering virtually every structural cell in the body, so no harm, no foul to leave the collagen fibers there, but now they're not attached to the next and the next and the next. So that's what we believe is happening. Here's an artist's rendering of that bond and where we believe we are detaching the bonds between collagen fibers and whatever they are attached to. As we do this, we are detaching the very core of cross-linking that occurs with all healing. These bonds are the building blocks of adhesions. Pregnancy rates for our patients with endometriosis were at nearly 56%, 128 pregnancies out of 299 women. When we compared those with medications and surgeries, we see that the therapy actually did very well for these women as far as pregnancies. As a matter of fact, here we can see the breakdown of women with endometriosis, those with endo and blocked fallopian tubes, IVF for a patient who is diagnosed with endometriosis who then goes to IVF, their success rate was 55%, which is nice. We were surprised to find a 40% pregnancy rate in women who were diagnosed with both endometriosis and FSH levels over 10, levels that are generally refused by reproductive physicians for in vitro fertilization. We'll talk a little bit more about that. Polycystic ovarian syndrome, we had 15 out of 28. 28 is still a decent number. The biostatistician told us 14 of those were by natural conception and 1 by in vitro fertilization. When we compared polycystic ovarian syndrome treated by this therapy with other techniques for treating PCOS infertility, those results were all over the board. So a woman may be better to just get clomiphene citrate, according to this. It was a small study, but nearly 67% success rate. But still, the therapy came in at close to 54% on polycystic ovarian syndrome. We had very few patients that applied for therapy with premature ovarian failure, and we did not do well with them. Only 1 of 5 became pregnant. She had a natural pregnancy, but this woman was aged only 30, so the jury is a bit out on that. We don't look like we do that well with premature ovarian failure. FSH became a fascinating subject for us. We had no reason to think we could help hormone levels. When we had women that called us and said, I have high FSH, do you think we can help? We asked Dr. King, and our advisor, who's by then left the hospital and just joined us, he's never charged me anything for his assistance. He just feels like it's such a potential boon to humankind and womankind. He wants to help. He said, Larry, no, I can see where you're helping sperm meet egg, but this is hormonal. I don't think you can help that. So then a woman came in. We were treating her for pelvic pain and scarring. I did not even realize she had been refused IVF the 3 prior months. If you have a FSH levels above 10, as I mentioned, you're generally going to be refused for IVF, and her levels the prior 3 months were 18, 19, and then 28, which indicates full menopause. So she was not able to become pregnant or acceptable to an in vitro fertilization cycle. But we treated her. She went home and got pregnant the next month naturally. What is going on? So I asked Dr. King, I said, what should we do with this? And he said, Larry, not only should you treat these women, but you need to check their FSH before and after therapy and see if this was just a one-off fluke or if there's really something there. That is the scientific method. That's how you make discoveries in science. So we did a FSH pilot study exactly that way. We had 16 women. Biostatistician said we should have at least 8. We had 16, which was great. The average FSH before therapy among these 16 women, shown there, it was a little over 20. There's the range of them. The average FSH after therapy had dropped significantly, dropped almost 9 points. And the first patient who, this was 2 years later when we're developing these statistics, by the time we got a chance to look at them, the first woman who had been refused IVF 3 times in a row, became pregnant naturally, had that child. 2 years later, as we're gathering this data, and I called her up, she's, oh, I'm pregnant again, naturally. So 2 years after she was supposed to be in full menopause. So that started to get our attention on looking at high FSH, and again asking, how in the world can we be helping hormonal levels in these women? In that first pilot study of the 16 women, 6 of them became pregnant before they had a chance to check their FSH afterwards. So they had a 38% pregnancy rate. Certainly we had good information in our 10-year study. Elevated FSH pregnancies, we had a 39% success rate, very similar to our initial pilot study. Once again, 43 of those by natural conception and 5 by in vitro fertilization. There's no comparison that we could find for FSH pregnancies because we just don't know what physicians do for high FSH. They generally send them for donor eggs, is our understanding. In looking at how in the world we could possibly affect this, we knew that there is a very strong dural connection between the tailbone, where the dura, the very strong sleeve that surrounds and protects the spinal cord, goes all the way through this tunnel of vertebrae up to the occiput at the base of the skull, and attaches there at the base of the skull, and then goes into the cranium and surrounds and separates virtually every structure in the cranium. Therefore, we're already treating internally some, and some of these women did have that tailbone pushed way forward, and we feel like, well, if that tailbone is pulled forward, it's pulling on the back of the head. It could be affecting that. Is that possible? If so, it would be exerting a downward pull on the dura and possibly imposing on cranial structures. So we started looking at the cranial structures. We know that there are 22 major bones on the cranium. They don't move much, but they're a bit like continental shelves on the surface of the earth, where they will move a little bit. There are actually glide marks that you can see on cranial bones, where they glide over each other. About in the center, articulating with most of the bones of the cranium, is the sphenoid bone, and in the center of the sphenoid, very well protected, is the pituitary hypothalamus, right in the middle of the head. Here's a side view of it, and you can see the sphenoid really totally surrounding that pituitary and hypothalamus as it hangs down in a closer look at that structure. So we know that communication between the pituitary, which emits FSH, and the ovary down in the pelvis is so important. We speculate a fall early in life maybe pushes the tailbone forward, causing a pull on the occiput through the dura and imposing on the adjoining sphenoid and the pituitary, and that by going in there and extending the sacrococcygeal joint, that we may be decreasing pressure on the pituitary. And a lot of these women do have neck pain or pain at the base of the skull or where the dura attaches at the temple or the top of the head, and improving the pituitary hypothalamus ovarian axis. This is all speculation because we had the data before we have the reason why it's working. We know that we improved FSH levels or had pregnancies in nearly 50% of 122 women, and that 39% of them became pregnant, most of them naturally and 5 by IVF. We're getting close to the end now. Speaking of in vitro fertilization, we did have quite a few women that we treated, 146 who went on to in vitro fertilization. Of those, 82 became pregnant. These are women that we treated within 15 months before embryo transfer. We looked up through the U.S. Centers for Disease Control and SART, the Society for Assisted Reproductive Techniques, the embryo transfer pregnancy rates for the entire United States, and our rate was 1.5 times the national average. So that was really quite surprising and quite good. We don't know if the reason is because we're freeing up so much at the uterus, creating a better environment for implantation, or whether it has to do with improving hormone levels or the PHO axis. We do know that when we did a calculation by age category. The p-values, the probability values statistically were off the chart in all cases. So these are considered quite valid numbers. Shows better on this chart where the gray represents the national rates without our therapy. That is for ages below 35, 45%, but if they get therapy within 15 months before the transfer, 68%, and so forth on down the line. Look at the ones over 40 years old. Instead of a 19% or a 9% fertility rate, we are seeing rates at 44 and 54% pregnancies in women over 40 years of age. So for reproductive endocrinologists who have older women or those with high FSH, where you are reluctant to start a cycle with them, these are the women you may want to consider to refer to us, and let's give it a try. Let's create some data and do some further research and help us figure out exactly why all this is working, but let's help these women out while we can. Every good study measures adverse events. In our case, it all being an outpatient therapy, it's just 20 hours of therapy over 5 days. Most people fly in on the weekend, start Monday morning, receive 4 hours of therapy each day, 2 hours in the morning, a break for lunch, 2 hours in the afternoon, and are done Friday afternoon. Because of this being an outpatient patient manual therapy, we suspect the adverse events were very temporary and not harmful at all, shown here. Generally some tenderness. I mentioned that we do some internal treatment. I talked much earlier about how bacteria can enter the vagina and grow. We had women start calling us that were telling us, I'm having orgasms like I've never had in my life, and I'm 45. Dr. King insisted that we do a study on that and said that there are ways to measure the domains of sexual dysfunction, and there are 6 major domains: desire, arousal, lubrication, orgasm, satisfaction, and pain. These are the numbers from a study of 23 women that was published again in PubMed, available to you through our website if you'd like to look at that, of the improvements for women in those domains. Quite dramatic improvements. We also did similar studies for women with endometriosis with similar results. The lowest being increased orgasm by 64%, decreased pain by 93%, desire 71%, arousal 86%, so forth. The same studies, and we went a year out to match studies that were done surgically for treating women with endometriosis and for pain decreases. So a year out, these were our results in treating 18 women with menstruation-related pain. That is the end of my presentation. I thank you very much for attending. I hope you found some interest and were a bit intrigued by some of this. We have been. If you would like to get in touch, that's who I am, Larry Wurn. You may get in touch with me at the phone number above or at the email above, and I thank you for attending. Thank you.